Good morning. I'm Poonam Rao. I'm a PGY3 resident at Christus Health Texas A&M College of Medicine Intermedicine Residence Program. And today I will be walking you through my case, which is Heart Under Siege, a rare case of primary cardiac angiosarcoma. Primary cardiac angiosarcoma is an exceedingly rare malignancy, yet it represents the most common form of malignant primary cardiac tumors. As you can see in the images, a lot of these patients have the tumor in the right atrium. They originate from the mesenchymal angioblast, and they are characterized by hemorrhage and necrosis within the tumor itself. The clinical manifestation in these patients who are males in their young 30s can vary depending on where the tumor is invading and the presence of metastasis. They often present non-specifically with complaints of chest pain, dyspnea, orthopnea, and peripheral edema. Diagnostic imaging, especially of the chest, is critical in identifying these patients. So talking about my patient, he was a young 30-year-old African-American police officer with no prior past medical history. He presented to the ED first time with complaints of chest pain, which he described as pleuritic in nature, getting better when he would lean forward. His EKG was very characteristic of pericarditis with diffuse ST elevations and PR depressions. His troponins were normal. Echo was done that showed mild pericardial effusion, but no signs of tamponade. So he got the diagnosis of acute pericarditis managed with NSAIDs, ibuprofen 800 milligram, and asked to follow up in the cardiology clinic. When he came to the cardiology clinic, he had a POCUS that showed increase in the effusion. The patient was asked to go to ED for pericardiocentesis. When he came to the ED, he had a syncopal episode prompting an urgent pericardiocentesis with the drainage of 1.3 liters bloody fluid. At this point, the patient was treated with steroids and high-dose NSAIDs with significant improvement and discharged home on ibuprofen and colchicine. Unfortunately, within 6 weeks, the patient presented back with more pain, requiring surgical intervention with evacuation of a hematoma, pericardial resection, and epicardial tear repairs. At that point, as you can see in figure 2, a CT was done, which showed a large mass in the right side, which was 7.4 into 5.6 centimeter, and there was concern that it was communicating with the SVC as well as the right atrium. The MRI was also done at that point, which shows that he had bilateral masses in his adrenal glands, concerning for metastatic disease. A biopsy was done, which showed malignant spindle cell neoplasm, and the immunoprofile was highly suggestive of angiosarcoma. Unfortunately, our patient did not make it, despite requiring chemotherapy. So despite the rarity of this condition, I want you all to have PCA in your diagnosis, especially in these young males who are presenting with non-specific presentations like chest pain. Echo is important in initial imaging modality, but imaging, especially like a CT and MRI of their chest, is required for early diagnosis. Oftentimes, these patients will require a PET scan. Definitive diagnosis still relies on the pathology and the immunohistochemistry. Surgery still remains the mainstay of treatment, but despite the benefits shown with chemoradiotherapy and immunotherapy, the prognosis of these patients remain poor. Thank you.